Good afternoon. My name is Matthew Clay, and I'm with JBS International. Thank you for joining us for today's webinar, Developing the Behavioral Health Crisis Continuum Learning Collaborative. Before we begin, I would like to review some housekeeping items. Due to the high number of participants on this call, all participant lines will be muted for the duration of this webinar session. If you have any comments or questions, please submit them at any time by using the Q&A feature. To open your Q&A window, please click on the Q&A icon located in the bottom center of your Zoom window. Closed captioning is also available. You can view the captions in your browser by clicking on the AI media link in the chat. Or depending on your screen size, you can go to the ellipses at the bottom of the screen below More to show captions and change their size. Or you can use the caret beside the closed caption notation located at the bottom of your screen. If you experience any technical issues during this webinar, please message us using the chat feature, which is located at the bottom center of your screen, or email us at samsastateta@jbsinternational.com. Lastly, this is a recorded event, and your participation grants consent to be recorded. The recorded webinar and PowerPoint slides will be available and sent to participants at a later date. Next slide. The views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, the Substance Abuse and Mental Health Services Administration, or the U.S. Department of Health and Human Services. I'm now turning it over to Annika Vartan of Apt Associates to get us started. Annika?
Good morning and good afternoon, everyone. I'm Annika Vartan from Apt Associates, a co-facilitator of today's webinar and the facilitator of the Crisis Continuum Learning Collaborative. Please use the chat feature to share with us your name and your role or position in your state, just so everybody can get acquainted. The purpose of today's webinar, next slide, please, is to provide an overview of the SAMHSA-sponsored Behavioral Health Crisis Continuum Learning Collaborative series, which took place with select states in June and July of this year. Today's agenda includes an overview of the work of the Learning Collaborative, presentation by two states that participated, Alabama and Alaska, and a guest speaker, Debbie Atkins, who will talk about data, systems, and performance improvement of the crisis continuum systems. We will then have time for Q&A with the presenters and close the session with an evaluation by the webinar participants. And next slide. Now I would like to welcome Dr. Belina Shaw from SAMHSA for welcoming remarks.
And Annika, Dr. Everett will be just a moment late, so we'll come back to her. So let's go ahead and move to the next slide.
Oh, I'm here. Hello.
Oh, beautiful. Sorry about that, Dr.
Wonderful.
Everett.
Then give me a second to introduce you, Dr. Everett.
Okay, sure. Sorry.
Dr. Anita Everett is the director of SAMHSA Center for Mental Health Services. And prior to rejoining SAMHSA as the chief medical officer and then CMTS director, Dr. Everett served as the president of the American Psychiatric Association, the president of the American Association of Community Psychiatrists, and the section chief of the Johns Hopkins Bayview Community Psychiatry Program in Baltimore, Maryland, where she directed 22 community programs that provided a range of services to individuals from preschool age to older adults, including intensive acute services and recovery support services. So Dr. Everett is your colleague in and out. Dr. Everett, welcome to the virtual stage.
Great. Thank you very much. And I apologize for being late. That's the last thing you want as a meeting organizer is to have, have one of the people at the beginning of the agenda. Anyway, I apologize for that. But I am here now. Could we take down? I don't have slides. Could we take that down while I'm speaking and then we'll put it back up when? Yeah, thank you. So that way we can see anyone who does have their camera on. I can tell if there's questions, things like that. So thank you very much for having me as part of this. I want to welcome the states and territories that are in attendance today for today's Developing the Behavioral Health Crisis Continuum webinar, which is presented by SAMHSA in partnership with JBS and APT Services, or APT, the companies. Before we get started, I'd like to provide you a few comments to set the stage for today's presentation. So we're moving from general orientation on into a little bit more of the details. Today's webinar is a culmination of a highly interactive six-session learning collaborative that the following states and territories completed: Alabama, Alaska, Arizona, the Northern Mariana Islands, Washington, D.C., Indiana, Kentucky, and the Marshall Islands. So last spring, these states and territories applied and were selected to participate in the Learning Collaborative. There were only 8 spots available, so unfortunately, not every state who applied was able to participate. We will have additional learning community opportunities available for states in federal fiscal year 24, more on that later, and we really genuinely hope that you found it to be a very valuable experience. For this Crisis Learning Center, the first session took place in person at SAMHSA's headquarters in Rockville, Maryland in June, while the remaining sessions were conducted virtually, with the final session ending in July. Each session included subject matter experts presenting best practices, breakout discussions for participants to interact and engage with one another, and activities to reinforce lessons. Session topics included crisis system integration and quality measurement, financing, strategies for supporting the crisis continuum workforce, and others. The purpose of today's webinar is to ensure that the work, lessons learned, and key findings from the collaborative are shared with a broader audience. And also, so that we work from a common frame. Each of us that works in SAMHSA in this area fundamentally believes that suicide is a preventable concern in the United States. So we are behind that and behind these activities 100%. Today's presentation includes several state participants that are sharing their takeaways by way of the state spotlights. As these spotlights are shared, I encourage each one of you to consider the ways these lessons could be applied in your particular state. If anyone in attendance wants to connect with a state who completed the learning community to learn more about their experiences, they may do so by emailing JBS at samhsastateta@jbsinternational.com. Hopefully that will be able to be put in the chat as well, that email, so anyone who's with us today can write in and to learn more. So JBS is part of their job with us to facilitate that connection. We've hired them to do that with us on your behalf. As a companion to this webinar, SAMHSA and JBS are also developing a brief resource document which summarizes the common themes and lessons learned throughout the Learning Collaborative. This document will be released in the coming weeks. Future learning collaboratives we anticipate will include learning collaboratives on, let me give you a little bit of a context first. I apologize, jumped ahead of myself. This learning collaborative was held as a part of the Center for Mental Health Services state TA contract. This contract is funded by SAMHSA to support states in use of the Community Mental Health Services Block Grant, affectionately known as the Mental Health Block Grant. This grant series, this block grant series, which is given to every state proportional to their population overall, its purpose is to support the community integration and services for individuals with serious mental illness or at risk for those, and children with serious emotional disturbances or at risk for those. There will be new learning collaboratives available to states throughout the state TA, or because of the state TA contract, in federal fiscal year 2024, which starts for us October 1st. As with this year, because of the limited number of spots, there will be an application process. States that are interested in applying should be on the lookout for further instructions from JBS and their government project officers, their GPO. Any questions may also be directed to your government project office that's responsible for managing the block grant in your state. SAMHSA is committed to supporting our partners in the states and jurisdictions as they strive to meet the behavioral health needs of their communities. This state TA learning collaborative is one way states can take advantage of this support. You can also request individualized TA or technical assistance on and off site directly from JBS, which Matt will tell you more about, or you can always reach out to your government project officer with questions. Before I turn it back to the facilitator to get us started, I want to thank each of you in attendance today. SAMHSA acknowledges your commitment to improving your systems, and we thank you for your hard work. A special thanks to the participants in this learning collaborative for their work, their support for one another during the collaborative, and their willingness to share their lessons learned with all of us today. I will say as a sort of final closing thought, your success is our success, and we're very interested and invested in the success of your state programs in advancing suicide prevention so that fewer Americans die by suicide. Thank you, and with that, I'll turn it back over.
Thank you, Dr. Everett. And we're pulling the slides back up. And now will be my turn to share with you some of the learnings from the Crisis Continuum Learning Collaborative. So our objectives were to share and learn best practices and promising approaches for planning, implementing, and expanding state behavioral health crisis systems, identify challenges with a focus on developing crisis receiving and stabilization services, find ways to expand peer learning, and document best practices and promising approaches, as Dr. Everett said, that were discussed by participants for sharing with all community mental health services block grant recipients. And this is what we've started doing today through this webinar. Next slide. We all followed one mantra. Everyone teaches and everyone learns. Next. Participants were selected based on their geographic diversity, need, varying degrees of challenges to the crisis continuum systems, and their motivation to participate. Next. As states came to the Learning Collaborative with objectives that they could jumpstart through their participation in the Learning Collaborative and start implementing within 6 to 12 months. For many of the states, as you see on the slide, their objectives focused on service improvement and expansion and workforce recruitment and development. Some focused on developing policies and procedures for crisis response, others on decreasing youth hospitalization by increasing intermediate levels of care, and evaluation of integrating residential programs and same-day appointment functionality. Next slide, please. And as we discussed interests and challenges in each state, participants learned that despite the geographic, cultural, and operational differences, they had a lot in common. A few states were benefiting from legislative support, while a few other states were struggling with the lack of such support. States were looking to develop a unified IT platform for their system. Some were constantly working on getting buy-in from stakeholders who were fearful of change. Development of services for children and adolescents was a priority for many, as well as providing adequate services in remote areas and developing a no wrong door approach where everyone can get services regardless of their age, ability, location, mental health issue, or ability to pay. Next slide. And I want to share with you a few strategies that states developed, discussed, or tested for crisis system integration. Build collaboration among all interested parties, community providers, legislators, and stakeholders associated with the entire behavioral health system. Use available 988 funding to expand workforce in crisis centers. Use heightened awareness of the mental health crisis in the country to engage with new partners and to push for greater coordination. Identify good data points to measure progress and performance. And there you can start small with fewer measures that can be used to improve services and get community and legislative buy-in. Next slide, please. For financing the state crisis system, a few of the strategies. Identify pros and cons of available funding systems. Account for the substantial variances in resources in the rural and urban areas. Map funds for utilization in all geographic areas of need and carve out funds for different population groups. In grant applications, shape the language to allow provider flexibility while ensuring consistency. Interpret flexibility of grant funding clearly to help keep providers from audit risk, from being exposed to audit risks. Use data to build a case with legislature on the impact and importance of additional funding. Hit them with numbers, as one of the participants said. Select data points that speak to them, like reducing hospitalizations and ER visits, reducing involvement in the criminal justice system, reducing involuntary commitments, because those are extremely expensive on multiple fronts, or reducing burden on the state's child protective services as we de-escalate children and empower parents in their home and meet them where they are. Engage with community advocates, especially when the state staff is lean. They can amplify the voice for the need for increased funding. Be aware of funding stream requirements, which are for Medicaid recipients and which are not. And establish sustainable practices, establish a base for key populations, and build infrastructure while federal funding is available. Next slide. To integrate law enforcement into program design. Put 988 staff, social workers with 911 dispatchers. This will help them develop shared language and bring agencies together to learn similarities and differences. Make police visits worthwhile to them. Provide help with reports as they do drop-offs. Let them in and out within 10 to 15 minutes. Provide access to restrooms and documenting office. Build relationships. Meet in person to form connections and understand both sides. Figure out what is our joint goal instead of having a power struggle. Create win-win situations between behavioral health and law enforcement. Show that collaboration with behavioral health makes their job easier and they are using fewer officers. Have law enforcement officers lead crisis trainings for other officers. Operationalize training. Talk about what training looks like in practice and ensure appropriate training based on geographic area so that interventions are tailored to the population, to the cultural norms in the area. Develop welcome packets for new law enforcement leadership with information that is needed to continue the process that's been started by their predecessors. Hold community summits, bringing local law enforcement together with behavioral health agencies to talk through training, data, and policies. And educate law enforcement on how things are funded, and if funding sources are related, have conversations around potential joint work instead of creating siloed systems. Next slide. And now strategies developed to improve crisis receiving model. At virtual monthly crisis continuum meetings with counties, solicit community and area-specific ideas and solutions for crisis stabilization services that build on community strengths and resources. Think through all the pros and cons of mobile crisis teams transporting the patient in crisis from remote area to the facility in the center, and then amend policies accordingly. Influence policies that limit transportation of patients to ER, where first responders only get paid if they take the patient to emergency department. Influence those state policies if you're looking to establish a co-response model with the ambulance services. Adjust policies and culture to transition from historically heavy medical model of behavioral health care to a service model that does not rely heavily on medical intervention. Be clear on your vision and do transition planning with leadership on how to get from where we are now to where we want to be. Next. Finally, participants discussed workforce-related strategies. And just to give you a few highlights. For recruitment strategies, change certification requirements for peer support specialists to have the right people for right positions. and use peers as part of corresponding team, not assigned to a specific agency, but as a bank to be called upon in need. Advertise and provide remote work. As training and professional development strategies, what we came up with was offer continued education unit credits and certification. Established a postgraduate residency program. For training, use adult strategies such as adult learning strategies, such as Audible books and shorter asynchronous trainings. Pay for graduate degree in return for work for the organization after graduation. Participants also focused heavily on staff retention strategies. Some of the strategies are give clinicians choices for time and space of their work, create schedules that support people. You may want to consider having, for instance, the 3 12-hour days or a 4-day work week. Train supervisors to manage people who are not in the office. Provide trauma-informed training for supervision. Help pay student loans. And more simple things like value paid time off, allow people to fully disconnect when they take vacation or sick leave. Next slide. And now I would like you to hear from the Learning Collaborative participants themselves. I welcome to this virtual stage our colleagues from the Alabama Department of Mental Health, Shalandra Rogers, CCBHC State Project Director, and Anthony Reynolds, Crisis Care Project Director.
Annika, thank you so much. And from the state of Alabama to everyone, we are so thankful for the opportunity that we had to participate in such a wonderful learning experience. I was just listening to Dr. Everett as she was speaking, and I figured out how we were selected, Anthony. It was an application process. So we were very grateful to have had the opportunity to learn from our colleagues from the other 7 states. Shout out to everyone for what they brought to the table. For Alabama, our participation allowed for us to collaborate on another level. You know, we have the collaboration here at work with our colleagues here, but to experience the collaboration and to hear what others from other states are doing was just really eye-opening for us, because it really taught us a lot, and it taught us, you know, that we're on the right track. So we were very thankful for that opportunity. So with that, Anthony.
Yes, hello, Anthony Reynolds, a Crisis Care Project Director. When I came into this position, I studied the best practices, the SAMHSA best practices and all, and the 3 major components. However, I found out internally, we had like a lot of trains going down tracks, separate tracks. So this TA really brought together, allowed us in the state of Alabama to pull together all our crisis system of care components under one. It's kind of under my leadership, but we have a lot of very talented positions in Alabama that are doing like the 988. Our providers already have a system of access to care. So it allowed us to kind of pull those together under one direction. We had the mobile crisis services in Alabama, as I'm sure in other states, and found that out from working with other states. They were really through 3 or 4 different funding sources. So it kind of gives some fragmentation when you got different funding sources and answering to different people. So it allowed us to pull that together. I'm going to go more into detail about the mobile crisis on the next slide, but also Alabama, we're very proud. Our legislature and governor, under the direction of our commissioner, have funded 6 regional crisis stabilization centers with sustainable state funding, with no federal funding. So this really helped pull that in and where it fits in. And then it also allowed Shalandra, my partner there, to really bond, because we got to go to Washington together, got to go eat a lot and have fun, but She was appointed recently to the CCBHC project director. So it allowed us to pull all this together under that. And I'll pass on to Shalandra.
Yes, Anthony, thank you. Such a perfect segue. He's right. I was afforded the opportunity to become the CCBAC project director right around the same time that we were told that we had been accepted into the learning collaborative. So for me, just to be able to experience such a high level of learning and to have all of that, like come together for me in my new role, it just really spoke volumes to just my overall learning. It allowed us to kind of see things from a different plane, from a different level. And it also brought oversight and direction to us as we're starting out with, CCBHC and Anthony with his crisis services across the state and how we need to provide more robust services in these areas. And also just to make sure that we are complementing our services to increase the requirements of our crisis centers, as well as to meet the requirements of our CCBHC planning grant, which we were just awarded that grant here this year in 2023. Next slide, please.
Yes, and another part, sometimes you have a perfect storm that's negative. This was a perfect storm that was positive, and the timing was perfect for the TA because we were in the last stages of our mobile crisis state planning grant, which is, I'm sure some of you out there are involved with, that ended just September the 30th. But it was 3 different organizations. That CMS planning grant was through our state Department of Medicaid Services. They had subcontracted the University of Alabama, which is a vital through the social work department at the University of Alabama. They took, and this is a resource for you. I'm not going to go through these 17 concepts, but they took the best practices concepts and pulled out and came a justification to screen and assess mobile crisis services that we had in place. And we went to each location and used these. This is a very abbreviated list of the 17. It's going to be on the resource list that's going to be posted. It's called a crisis resource document that our friends here that organize this TA, they go post this, but take for example, team structure, they go have a very detailed description of what team structure is for the best practices and how to assess it. So you can take this, we have permission from our vital partners and from DMH, Department of Mental Health, and from Medicaid to share this publicly. So I would really print this out. It's in a booklet form, broke out very detailed. And we used it to interview participants and move forward with that. And so it came straight out of the guidelines. But, when you look at those guidelines, it talks about the 3 concepts. This pulled out just for mobile crisis. So that was great. And next slide.
So we Anthony and I were able to sit down with one another, and we were able to, kind of talk through our takeaways. I mentioned some of those earlier, just the camaraderie of being around the different states and the energy that was brought to the group, excuse me, was just really exponential for me. I had never been to anything like this. So just to be a part of this on a different professional level was awesome. I would just encourage you, if you do have the opportunity to participate or to apply and be accepted to one of these TAs, is to be open to the learning process. I had no idea what to expect as we were going into it, but I came out with a lot. So just be open to the process, embrace the camaraderie of the group. It's not a hare's race. Everybody is on their own accord, and everybody is, where they are in the process. So, just learn from everybody in the group and don't compare yourself to you know, others and where they may be along the continuum of care, but just enjoy it, embrace it, because it really goes fast. I mean, we were up there for a day and then we came back and we did 6 webinars, but you know, it was packed, but it was worth it. So just be open to the whole process of it and enjoy. Anthony?
Yes, I totally agree with everything Shalandra said, and just would reinforce, if you have an opportunity, apply and participate in a state TA learning collaborative. My background is counseling, done a lot of group therapy. Folks walk into group dynamics and intimidate and all, but when a few people start self-disclosing, you learn about them, learn about some of the struggles. One of the states that was with us, I'm not going to name them, call them out, that we thought were so far advanced. You know, they were telling us, we've been working on this 40 years and we're still having struggles. So I know this is going to be a process, and it made me accept that. It's kind of like what we tell our clients when we work individual clients. Recovery is a process. It's not an event. It doesn't happen today. So really, the breakout groups where you really got to know people on a much more intimate learning level was very important. So I just reinforce, if you have the opportunity, and the guidance we had by the professionals, Annika, and I can't name everybody. There was as many professionals there to help us as it was participants. So having that resource and having that contact is excellent for now and future. So I think we got through our time pretty quick, and we'll be available for questions at the end. Thank you, Shalandra.
Thank you, Anthony.
Thank you, Shalandra and Anthony, and thank you for your warm words about a group that came together at the Learning Collaborative. As a reminder, I want to ask our attendees to please send your questions for the panelists via Q&A chat so we can have them ready for the Q&A session. And now it's my pleasure to pass the mic to our colleagues from the Alaska Department of Health, Dr. Tina Velker-Ross, the Crisis Services Lead, and Heather Phelps, Mental Health Clinician and Policy Regulations and Planning Specialist.
Next slide, please. Thank you to Annika and to SAMHSA for allowing the state of Alaska to be involved with the Technical Assistance Collaborative. It was well worth it, and we just felt honored that we could be a part of it. So thank you. I just wanted to start with where we currently are in the state of Alaska, and that is we do have our 988 line established, and we're developing mobile crisis teams and crisis stabilization centers. Currently, we are focusing on connecting our regional behavioral health providers with 988, and that is what we're doing is we're developing communication pathways so that 988 can connect individuals to their local providers in their communities. We're also really working to develop connections between component services of the crisis system in the communities that are implementing crisis services. And we're also working at building capacity and expanding those services and those providers out in our different regions through our 1115 Medicaid waiver demonstration project. Next slide, please. So while we are actually in the early development stage of our crisis continuum, we have strengths in that we currently have support of our leadership and our administration in developing the crisis services system. We have established partners at the state and local levels, and those partners are working together collaboratively. And we've identified the service structure in our 1115 Medicaid waiver demonstration project, which expanded our crisis services system to include services like mobile outreach, peer-based crisis services, 23-hour observation, and crisis residential services. We do, though, face a lot of challenges in Alaska in that we are a very large state with significant rural and remote areas. First, we really have to adjust the model to the rural locations that have really extraordinary challenges. Those challenges are things like higher levels of isolation, areas that are only accessible by plane or boat, broadband issues, and increased difficulty in securing workforce in those rural locations. Secondly, a challenge is ensuring that partners are working together, that the components involved are communicating. So, and that is just normative across the board, we found out. Thirdly, we're a fee-for-service state, and the crisis services that we have now are part of an expanded but a relatively new service structure for our providers. And lastly, the simultaneous development of services and policy. The challenges in the implementation of the service, then identifying the challenges or issues or barriers that emerge in that process, and needing to evolve our policy to address those problem areas or issues or set new standards in place. Though we continue to work on those issues, and part of our process is to, reframe challenges, normalizing that the evolving nature of the development of our crisis system, and just address issues as they arise, and acknowledging that we as a state and all of our providers are doing the best that they can do with the resources we have. Also, just continuing to develop those communication pathways to overcome our challenges, and ensuring that there is communication between our systems of care, the components of crisis services, and between the crisis system and our community outpatient behavioral health providers. And lastly, to overcome these challenges, we plan on just implementing technical assistance at the state level and at the provider level. Next slide, please. So in the 6 virtual weeks that we met, there were subject experts that presented. And I just selected one as my favorite, and that was a presentation done by Dr. Margie Balfour on crisis system integration and quality management. And she really talked a lot about identifying data measurement. And she talked about 2 types of frameworks. The first was the process-based framework that was really based on workflow and workflow processes and identifying data points within those processes. And the second framework she used was more of a values-based, and it had the acronym Access to Help. And so each letter represents what you might consider measuring related to that acronym, such as accessible, collaborative, comprehensive, equitable, safe, and successful. She also spoke about how crisis data can improve the whole behavioral health system. And I think this is a really important issue. The idea that every crisis visit is a story about an individual who couldn't get their needs met in the community. And turning those stories into data to reveal the trends that need to be improved in your overall behavioral health system. I think that's a really powerful way to use the data. And it also highlights that stories are just data with a soul. And that is that's a quote from Brené Brown. You can see more information related to crisis system integration and quality management measures in a report called Quality Management or Quality Measurement in Crisis Services, which is on the nationalcouncil.org website. Next slide, please. Finally, our key takeaway is that other states are a resource. Hearing what other states were implementing, how they're developing their crisis system, their processes and strategies, how they were moving through sort of their ups and downs, and finding out what they were doing to address their own challenges was really very helpful. And I just found that learning to reach out to other states to hear what they're doing, to ask for those resources. They were always willing to share. And so that was they were our resource and are a valuable resource, because everyone is different in terms of where they're at in developing their crisis continuum. And so you can always find someone in another state who can kind of connect you with more information to help you work through some of your own challenges. And I'm going to pass the mic over to Heather Phelps.
Thanks, Tina. Yeah, this was just a very invaluable process. I'm going to steal that language that Anthony said earlier. This is a process, and we're working through transformational change in our systems of care with the crisis continuum. And so with that, if we can move to the next slide, please. With that, we really were thinking about what were the takeaways from this really unique, dynamic process. And we kind of compared it to what SAMHSA's guidelines are for the continuum of crisis care, that we had someone to talk to in this collaborative, we have someone that was responding to us in a helpful way, and a place to go for further information. That we really felt like that this was so unique, so invaluable, and to be in person, especially after quite a few years with COVID, to have that unique, coming together all across the country, meeting people and exchanging ideas was just very, very powerful. For this, we really were thinking about, like, with this transformational change, this is really a journey. And when you're on a journey, you want to pack correctly. You want to think about what you need to take along in that journey, and who are you going to go on that journey with. And for us, it's really our state colleagues who are working in this field. Tina's already reached out to quite a few people that were in the collaborative for resources. You can bet that we're going to be reaching out to Alabama with their research that they've done on mobile crisis. This is really an area where we could share in our journey together. So what it does is it really, and Shalandra was talking about this too, not to compare, Alabama's so far ahead of us, or we're so far ahead of this other place, or it's really more about like normalizing that experience. And saying, hey, we're all kind of struggling with how to onboard these services. We all know that the need is great. We all want to be responsive. How do we do that within our unique frameworks, within our unique political system, administrative policies, regulations? How do we do this? And just hearing what other people are going through in other states really validated what we were going through. With someone to respond to, we really want to thank OPT and SAMHSA and JBS International for organizing and helping us. We never felt like we were alone or didn't know what was going on. Like Anthony said earlier, there were just as many, if not more, professionals there at the collaborative in person to really help us and really to provide that expert information. So again, this collaborative is just really important because you learn from each other and you learn from other experts as well. When we went to the collaborative, we had to identify our strengths, weaknesses, opportunities, and threats, or SWOT, which was kind of our overarching goals on what we wanted to work on. And that we got a lot of clarification about our SWOT goals. How could we make them better? The invaluable way of seeing other people's viewpoints and their experiences to apply to our SWOT. And then we had some accountability with that, because in the subsequent virtual learning platforms, we had to talk about what progress we were making with that SWOT. So we had ongoing response related to that. And then we had a variety of experts presenting on specific implementation topics. You heard Tina talking about Dr. Balfour. You're going to hear from Debbie Atkins here in a minute about some more information. But all the presenters were just top notch. We learned about like legal implementation, working with the law force, workforce development, funding, residential and receiving centers. It just a wide variety of information that we could pull from and use, and then a place to go. So Now we can still go to our colleagues. We formed those relationships. There's a resource document that you heard Alabama referencing that our partners are working on putting together. That information comes from us. It also includes other information. So it's a real living document. And then we also have these cached webinars that I was just even looking at a few of them the other day, because there's just so much great information in them that we can apply as we're doing our work. And we really do value this experience. We're so grateful that we were selected and get to talk with all these incredible people that we've met subsequently through the experience. Now I'll pass it on to whoever is going next.
Thank you so much, Tina. And some of our Learning Collaborative colleagues are here in the room. So it's exciting to have many of you back. Now allow me to introduce our subject matter expert and guest speaker, Debbie Atkins. Ms. Atkins is a Vice President for Growth at Carillon Behavioral Health, where she oversees new program design, development, and implementation. Next slide. Carillon Behavioral Health provides behavioral and specialty care services and crisis solutions to 47 million members across the country. Before joining Carillon, Ms. Atkins served as the Georgia Department of Behavioral Health and Developmental Disabilities for 10 years as a director of crisis coordination and the point person for 988 implementation. Ms. Atkins is a national expert and speaker in crisis management, intervention and communications, family therapy, program design and evaluation, and using data to drive crisis services. Ms. Atkins' presentation was much loved by the Learning Collaborative participants, and we wanted to bring her back. The collaborative participants actually voted to select the topic of her presentation today. Ms. Atkins, the floor is yours.
Thank you so much, Annika. It's a pleasure to be here. You can go to the next slide. So I was asked to speak. I'm not sure why my video is not showing. It was showing before.
We see you.
We're seeing you.
Okay. I just don't see myself. So that's good. I was asked to talk about technology, monitoring systems, and provider performance, and data sharing and use agreements, all that in 15 minutes. So as you can imagine, I'm going to do more to help states think about what you need to do in order to prepare for these versus knowing all you need to know when we finish our conversation. So you can go to the next slide. So first, let's talk about technology. It is the hot topic. Everyone wants it. Everyone is showing bright and shiny and new things, and every company is developing more and more as the days go by. Just remember, technology is a tool. It's a very valuable tool, but it doesn't replace your high quality workforce. And it can't, replace that human empathy and interaction that we get from the people that we train. The purpose of good technology is to improve your efficiencies, to make things run smoother, to make sure that the people who are answering calls or dispatching mobile can do it in a more streamlined way. It should make all of your services kind of come together. It is also to improve your data gathering. So by having technology, all the different pieces that you collect on spreadsheets and stories, it just brings it all together, and that's very important. So what do you need to know? You have all these choices to look at. Know what issue you're trying to solve for. Is it that you need just a system to help your call centers? Is it that you need it to do a lot more? Does it need to be integrated with other things? Do you need it customized, or is just off the shelf what everyone else is getting okay for you? Where are you in your process? You've heard all the states talk about, we're in the beginning stages. We're in a different stage. Does your software need to be okay for where you are now? And does it need to grow with you? The next thing is, what will your software need to connect to and with? And if it needs to connect to someone, will they allow it? Do you have the authority to say, yes, this technology will connect to you, whether that is from an MCO to your Medicaid unit to another software service that you might have in your system. I've heard states want you to connect to EHRs, and will the EHRs allow for that? So there's a lot that you have to consider. One of the big things when you're looking at technology is it secure? You've seen the data breaches, you get those emails that say your information has been leaked. That is the last thing as a state that you want to have to deal with when you're talking about health portability and information, right? So HIPAA is vital. We need to keep things very secure. So you need to talk to your vendors about what that security looks like. And ask for demos and references. Make sure it's what you think it is. Is it really active? Is this just a good screenshot? Ask for references from other states and make sure that there's states that are similar to yours. So if you're a Medicaid expansion state, are they working with other Medicaid expansion states? Are you a single call center state versus a multi-call center state? So all of these things play a little bit into what you're wanting to look for in your technology. You can go to the next slide and we break it down a little bit more. So have a pre-bid meeting. As a state agency, we talk about our technology all the time and we think through it in simple terms. Oh, they're going to get a feed from this, or oh, they're just going to connect to that. With technology, it may look different for someone bidding on those services for you. Have a question and answer time, or at least post bid, allow for some of that flexibility because there will be unknowns until you can have some pretty detailed conversations about the types of connections, the type of information. It's hard for some technologies to go ahead and cost that out before having that information. Every state is different, right? I'm preaching to the choir. This was one of the things I was very adamant about when I was at the state of Georgia, that no state looks alike. There are some similarities that we can glean from, but you need to know the demographics of your state and what that means for the technology you're purchasing. How many providers are you wanting to connect to? Like I said before, do you have one call center or do you have 15 call centers? Do you need the technology for all of them? Do you have different providers that are doing mobile crisis? Do you contract out to single providers for your mobile crisis? You know, Georgia did bids. We only had a few. Some states, it's for all willing and able. So what does that look like? Are you a Medicaid expansion state? Do you have private providers like in Washington state that are required to pay? So what are your number of payers? Who do you need to connect to? What does that need to look like? What are your current tech systems? So do you have legacy stuff that is in your state that you might want something to be integrated to? What about, call centers? Are they expected to pay to take on this new technology? If you have 11 and they're working off different platforms, what does that look like? Do you need them to be able to connect to Vibrant system? So these are just questions you need to think through. The last one, which was a shock to me, is population numbers. A lot of your tech companies will base your cost on your population. So be able to have the conversation of what is your penetration rate? While call centers are open to every member of your state, what is the percentage that is on average calling? Know your numbers, know what's trending, and you can get those just from your Vibrant numbers currently and look at those trends that you did for your early SAMHSA grants. Consider how much flexibility you need your technology to have. Does it need to be nimble? Do you feel like there are going to be a lot of changes coming up? Or do you feel like, you know what, if we get it 90%, we're good. We don't need it to be that flexible to have change orders. Some technologies can be changed pretty quickly. For a lower cost, some, it's very difficult and it's a lengthy process. So think through those things and ask those questions of the potential bidders and providers. Talk with states, again, similar to your state, about their technology. Ask them what they like, ask them what they didn't like. And then you have to go back and make that decision. Is that something we can live with? Does that really apply to our state? Don't be persuaded to buy something that you don't need. Consultants will be out there. They are selling what they know. They are selling technology to make money for themselves, or they're in your same boat and they went out and they polled a ton of providers or a ton of tech companies, and they're just investigating like you are. Know what you need, ask the questions, and don't be pressured. And know the best versions will be the most expensive. Know your budget. There are ranges of solutions for what you need. Does a solution offer a partial implementation, or do you have to buy the whole thing? In other words, could you just do the call center technology or just the mobile dispatch? Do you have to do all of it? Can some of it integrate in with other things so that you don't have to purchase what you might already have in a home version? So think through these questions when you talk to providers or when you're putting out an RFP, and this might help you get to the solutions you need. So you can go to the next slide, and we're going to talk a little bit about our monitoring systems and provider performance. So I know this is at top of mind for all states. We have all of these new services. We've been really trying just to get it out the gate, to get our providers up to speed, to figure out what we're procuring, and to have someone answer the phone, have someone to go out and have a place to go. Well, now it comes down to, how do we look at the quality of all this? What does it tell us? So you'll see I'm a big systems person, so it's a circle for me. You look at quality reviews, they should be bringing you actionable data, which should lead to your system improvements. So data does improve clinical understanding and service delivery if it's done well. You need the good data. You need the data that will help you transform your system. And sometimes it may not happen on the first try. You might have to come back and look at your data and say, we thought this is what we wanted to measure, but we need to finesse this a little bit. We want to measure something different because it's not giving us the information we thought we needed. So if it's not driving improved performance, you have to look at what's the purpose of it and why am I collecting it? You shouldn't just be collecting data as an additional requirement. It should be to inform you, to inform your providers, to inform your community. But no, transparency is difficult. That was probably one of the biggest change agents that we had to do when I brought data to Georgia. It brings transparency about your system, about your providers. We had to really assure that this data is not about a gotcha. It's not about a penalty or a fine. It's about, what are we learning? How can we use this? Why is this gap showing up? Is it our policies? Is it provider specific? Or is it really the system? And what we learned is that when you show the gaps and the needed improvements, you have to be prepared to now answer it, right? So now it's out there for everyone to see. We don't have enough crisis stabilization. We don't have enough licensed clinicians. You name it, you can fill in. What is the gap for your state? You need to know that the transparency will then cause you to have to do another strategic plan. And that's good, right? That moves system improvements, but you do have to work through that to make sure that you're doing this continuous quality improvement. You might choose to do quality improvement on your own. You might choose to bid that out and have an external person. It really depends on your state, what you have the expertise and the bandwidth for. The documents that were referenced on the websites on the full system, and I think Alaska talked about that last. And it's really important. It's probably in the pillars that they put. And it's the very bottom one, right? It's the system improvements and quality oversight. It's the foundation. Figure out what works for you and your state. You might be able to manage that all on your own. Other states might say, look, we don't have the bandwidth to even do what we're doing. We're going to move towards contracting that out. But those are discussions that you need to have internally and weigh and make decisions on what's the best route for us to do this quality improvement. You can go to the last slide. Okay, data sharing. So data sharing can look really different. So we're going to talk about things to consider, and then we're going to talk about some different examples of how we do data sharing. So things to consider when you're collecting your data and when you're sharing your data. Do you need a business associates agreement to even get data from some people? Do you need an MOU? Some states pull data from their MCOs, from their call centers, from their mobile crisis teams. So they want all of this data in one place. If you own all those contracts, you may not need anything to publish it. If you own some of the contracts and not other, you have to decide at what level of data that you can share publicly. HIPAA, of course, is always a consideration. We need to make sure that nothing that's identifiable is shared publicly. Looking at your multiple data sources, like I said, that can be from your billing. It could come from Vibrant. It can come from your providers themselves, from your tech systems, but look at all that's coming in. Sometimes it's not apples to apples, right? So data feeds that are coming in, what do they look like? How can you then get them into a full data warehouse and then manipulate that data to where it's something that you can report on? And then appropriateness of publishing data. This really relates to data can say anything you want it to say. You need to be careful what you put out, and you need to make sure that it's explained well. And I'll go through that a little bit more as I look at the different examples of data sharing, but you need to make sure that the audience knows how to interpret what you're putting out there. So some examples would be community collaboratives. This might be your local meetings. The data there might be more granular. You might really be trying to fix something that is in that community and you're driving change. Why are the hospitalization and ER visitation rates so high in this community? Why are police being called out more frequently in this community over another community? You're looking at the data, being able to drive some solutions for that specific group. Then there's dashboards. I probably should have put dashboards last. Dashboards are your high level. If dashboards are going out to the community, you need to make sure that it's very clear. You need to make sure that anyone who looks at it is going to walk away with what you intend for them to walk away. How many beds do we have available? What is our answer rate? Something very high level that is clear to, grade school students. They can look at it, they can see what that means. And then reporting. You can be a little bit more detailed in your reporting because you can footnote. Reporting can be published. Reporting goes out to, the different authorities like SAMHSA. And you're turning in a little bit higher up information. So when you kind of look at it, it can be granular. It can kind of be more of a broad base. And then it can be detailed, but still meaning something for that particular environment. I think that is my last slide. You can go. Yeah, I think we're down to questions and answers. So Annika, are you going to take over for questions or does it go back to Matt?
Thank you, Debbie. I'll step in, and thank you to all of our presenters for this afternoon's presentation. At this point in time, we will begin our question and answer segment of the presentation. If you have not already done so, we encourage you to submit any questions using the Q&A icon located at the bottom center of your screen. Our first question: are states moving away from responding with police when the crisis is in the community?
I don't mind answering this one. I just came from the statewide NAMI conference. The NAMI conference in Alabama this year was focused on CIT training. There were numerous police officers present. One of the CIT officers said they don't call it crisis intervention training. They call it crisis intervention team. Matter of fact, they received an award, and there was as many professionals, mental health professionals, mobile crisis teams, CMH providers, as there were police officers who got this award for a community in an area. So in some ways it is, but I think what I see us moving toward is more collaboration and more training between the mental health, mobile crisis, and police, law enforcement.
Our next question: What are best practices for integrating mobile crisis services with crisis receiving and stabilization facilities?
I don't mind jumping on this one too, because as your resource list, you will see that mobile crisis, 17 best practices, and some of our crisis centers, we had some that opened in the initial funding. We got new ones that are coming on this year. Most of the new ones are integrating and building their mobile crisis services and dispatch straight out of their stabilization center. So that shows that they go be totally involved. And what I've talked to mobile crisis teams, they're just so glad to have a place to go to with people instead of an emergency room. And I'll pass.
All right, and if there's others who want to add on, please feel free. Our next question: is there a best practice model for safe and recovery-oriented transport for individuals in crises other than law enforcement?
So I don't think anyone's going to jump in because this one's hard. I think it's hard for every state to figure out because transportation is just costly, right? So some states allow for ambulances to be paid to transfer. Some don't because they're not locked and someone can jump out the side. Some allow for families, especially for children, to transport if they feel that it is safe. It was hard. In Georgia, we actually found when I was there a couple of hospitals that purchased and retrofitted vans that were appropriate and safe. And they found that it was easier for them to transport someone out of their hospital to an appropriate behavioral health facility. And it was cheaper than having to wait on a sheriff to be able to have time to come. And so they found the funds to do that. Is that something that can expand out to the whole state? I doubt it. We just had a couple of big hospital systems that did that. So that was my 2 cents from what I've experienced, but I don't think there's an easy solution.
Thank you, Debbie. Our next question: what type of continuous quality improvement measures have states implemented?
So I think this is vast. I think Dr. Margie Balfour has put out quite a few papers. I actually used the papers that were referenced when I developed some of those quality improvements in Georgia. I think you have to start with what's measurable with your state. So where can you collect data and what do you have? That may not mean having a huge tech system. You know, we started with recidivism rates on spreadsheets and we got those, you know, turned in every day until we had the tech we needed. So I think you need to look at what do you have available first, and then look at the continuous quality. The value system that Dr. Balfour puts out is just vital, right? Are we treating people with integrity? Are we treating people like this is their worst day? And how do we support them? And how do you add those values in? So I would really suggest looking at the articles that were put out and then talk about, okay, from these value systems, what can we measure in our state? What can we not? And it has to be something that will really lead to change and action. So I would challenge you to kind of look at what data you have, what are your providers willing to be vulnerable about and looking at, and how can that drive that actionable data to make changes.
All right, thank you, Debbie. Our next question: what advice do you have for state personnel who may be new in their role?
I can take this. Because that's kind of what happened to me. I came to the state of Alaska in terms of my position a couple of years ago. And while I had a lot of experience in the crisis system and with administrative functions within systems of care. I wasn't necessarily an expert at that time on all the ins and outs. So what I did was I just participated in as many SAMHSA trainings as I could. I reviewed the guidelines, the national guidelines, and actually looked to the references they listed within those documents. And I attempted to connect with other sort of national training sites, NASHMED, and I attended the Crisis Jam once a week, right? Because that also gives you a lot of information. So I think right now we're in such a transformative time for crisis services that all you really have to do is really Google a question and look at the resources that come up. And there's lots of even YouTube videos. There's a lot of SAMHSA guidance documents, as well as NASHMED guidance documents and the National Council. So there's a lot of resources out there. And the other piece is just kind of what I also said in my presentation is it's okay to reach out to other states. I actually was very shy about it. And it really, people want to share what they know and what they've implemented. And there are some states who have kind of already invented the wheel in some respects and can kind of tell you some of what their challenges were. So that's kind of how I would answer that question.
Thanks, Tina. Our next question. How are states working to marry the services delivered by CCBHCs and those standalone stabilization centers and/or MCT?
So I'll speak to this one. So of course, with CCBHC, the crisis services is one of the required services of this particular model. So for the state of Alabama, prior to us receiving the planning grant, as Anthony mentioned, the crisis work was already in motion. So what we're doing now is just kind of looking to see where it does intersect, right? And we know that it does intersect because you have to have that as a component of the CCBHC. So we're just looking to see how we can, we're trying to figure out our PPS rate around that. We were able to write a SPA amendment for our Medicaid. And so with that work already being done, when we get ready to write our SPA for CCBHC, we'll already have that work done. So that's how we were able to marry like the administrative portions of that together. But for sure, there'll be some oversight in terms of what CCBHC requires in terms of the criteria and what Anthony and his teams are doing out in the community so that we can, make sure that everything is working beautifully together. So hopefully that answered your question.
Thank you, Shalandra.
Mm-hmm.
All right, our next question. What made the Learning Collaborative most beneficial? So for states who may be interested in hearing from our state participants, you talked about having different subject matter experts present. You referenced some of the breakout groups and the connections you formed with fellow states, or maybe even the shared resources. But what were some of the, what aspects of the Learning Collaborative were most helpful and why?
I think I'll start on that. So for us, I think having that first in-person meeting, I think that really set the tone for how all of the subsequent webinars went. I mean, just having that first in-person meeting with everybody and sitting at the table collectively, because for me, that was my second trip after COVID, right? So, I had got out of all of that, face-to-face interaction or whatnot, but just being there with Tina and I think Nicole and Andrew, I could name everybody. It was such an intimate group. Like just the size of the group made the learning fun, I think, whereas if you have 20 plus people, it makes it harder. But because the group was so small and we clicked, you know, it just made everything else about what we did. Although it was like every week, like you have to be committed to the time frame and everything that comes along with it. But I think just knowing that you were there with people that you had already bonded with made it even better. So that's my perspective.
Yeah, I would second that. And I would also say too, that we want to meet again. I mean, that's how much we bonded as a group, that we really value those connections that we made with individuals, that we really, you know, we are reaching out and continuing the conversation. So to me, yeah, what Shalandra said and seconding, and the energy is still there. That's the incredible thing about it. It's not oh, we went to this one thing and oh, you're never going to look at the PowerPoint again. It's definitely living, breathing, and alive.
I would also say another aspect that I found really helpful was because I might not always be doing it in my job, is really identifying what my goals and objectives were and rewriting them as they were evolving, as I was learning new information and as I was hearing what other people were doing, really objectifying the tasks that I needed to do as I was moving forward was helpful. And that, you know, it was homework assignment, and I probably came at it a little begrudgingly at first, thinking, what a minute, you know, but it was helpful to actually apply the information and say, how can I apply this to my state? And the other thing is the subject matter expert presentations were just tip top, and that information was very helpful. It's what I liked about that is hearing that information in a small group. You could wrestle with what pieces would work and would not work, and you ask those questions that you had, because no question was, you know, a wrong question. And you could hear how other people were attempting to apply the information as well. And so that there were different ways of thinking it through. So that I thought that was very helpful.
Great. Thanks, everyone. And just a reminder, if anyone in attendance has any questions for Debbie or for our state spotlight presenters, please submit your question using the Q&A box located on the bottom of your screen or the chat. Seeing no other questions, I'll now turn it back to Annika to close us out and offer some next steps. Annika?
Thank you, Matt. We have reached the final few minutes of today's webinar. I would like to encourage our state participants to reach out to the SAMHSA State TA project team to express your, can you go to the previous slide? I think it's the previous slide. One, yes, this one. Using this email to reach out to the SAMHSA State TA project team to express your interest in technical assistance on any topics related to developing your crisis system at whatever level of maturity you are, and express your interest also including in future for participation in future learning collaboratives, because we're now coming up with the topics of interest to the states, and we'll be announcing new learning collaboratives. So if you want to be part of those, raise your hand by emailing the project team. You can also find resources for mental health blog grantees in the links provided in this slide and also in the chat. I don't see them yet, but it's because I'm using multiple screens. But there should be links in the chat. JBS is also developing the crisis resource document that will conceptualize the key takeaways, lessons, content, and resources that we all either mentioned or the SMEs shared with us at the Learning Collaborative. The purpose of that document is to share the work of the Learning Collaborative more broadly with the states. It will also include that toolkit for evaluating the mobile crisis teams that Anthony talked about. This final resource document will be shared with states in the near future. And next slide, please. I would like to give a heartfelt thanks to today's panelists, Shalandra Rogers, Anthony Reynolds, Tina Velker-Ross, Heather Phelps, and Debbie Atkins for sharing your knowledge and experience with us. You're fantastic speakers. I always learn something when you take the mic, and I hope that others did today as well. And now, before you go, please complete the evaluation of today's webinar by either using the link in the chat or using your smartphone to help us with planning future learning events. It will only take you a few minutes. And this concludes today's final webinar on SAMHSA's Mental Health Crisis Continuum Learning Collaborative. And I hope to see many of you at the next, at future learning collaborative.